Path. Is it Prateik? Chronic
Yes, sir.
hepatitis. We will be talking about
Chronic
hepatitis.
hepatitis, yes, sir. Chronic hepatitis.
So
Chronic
we are live
hepatitis.
now.
Sir,
Rohan.
we are
Yeah,
live
Rohan,
now.
you can start. Yeah.
Yeah.
Very good evening to everyone.
Permission of
Thank
Dr.
you so much
Yeah.
for joining us. So we are here on the sixth installment of our monthly event, that is on medicinal adherence, brought to you by MedpeR. So this is the sixth event. We have had 5 events all through January to May. This is the sixth event of our show, and we hope to continue this. So today, in order to introduce the guests and speakers for today, I initially welcome Dr. Shambho Shamrat Shamazdar, who is our to begin the sessions and introduce our chief guests and other speakers. Dr. Shamazdar is also a respected speaker for our event tonight. So, Dr.
Okay.
Shamazdar, if you please come.
Yeah.
Thank
So
you.
thank you, Rohan. So actually, today we have a galaxy of chairperson and speakers with us. We have Professor Prabir Kumar Banerjee sir, who is a pioneer, or we can say teacher of teachers in the field of gastroenterology. He was professor in the Department of Gastroenterology in SSKM Hospital. And welcome you, sir, in today's event. And it is always honor for me to introduce my mentor, my guide, Professor Santanu Kumar Tripathi, sir, who is a renowned clinical pharmacologist. And he was ex-prof, professor and head Department of Clinical Pharmacology, School of Tropical Medicine. So now I request Tripathi sir and Prabir sir to take care of this event. With their permission, may I introduce, and it is my immense pleasure because uh, he is my senior, and he is one of the we can say now frontline warrior against COVID-19 pandemic. Uh, Famous internist in the city, Dr. Rahul Jain. Uh, Welcome you, Rahul da. It is actually my pleasure to have you in this stage, and my friend today. I have my friend, and for whom we the batchmates are always proud that he is again a young gastroenterologist in the city. And welcome you, Dr. Prateik Poddar, who is a very renowned gastroenterologist in the city. Uh, Now over to Tripathi sir and Prabir sir.
Thank you, Dr. Shambho. And it's a very great opportunity today to have this galaxy of expert gastroenterologists to be amongst us today, along with Dr. Shambho, who is a clinical pharmacologist and also a very busy practitioner. Today, will be our discussion topic is actually to focus on the importance of adherence, treatment adherence for the long-term management in some gastrointestinal disorders. We are fortunate to have amongst us a very senior gastroenterologist of the city and who has national and international fame, and that is Professor Prabir Banerjee, who is a senior elder of mine, and I'm fortunate to have worked with him at IPGMER SSKM Hospital, and then it's a great reunion, and for the last few years we again have re-established our contact and connection. We are fortunate to have you, Professor Banerjee, today, and who could be a better person than you to really steer today's discussion and deliberation. I'm also fortunate to have our young friends, young uh, specialists here, Dr. Rahul Jain and Dr. Prateik. So, along with, of course, Dr. Shambho, to take us through some of the uh, very, uh, you can say, the important areas of gastroenterology, some of the important focus areas, and we will really enjoy the deliberations today. And I'm sure many people who are listening today, they will benefit immensely by listening to these deliberations. Without standing between the galaxy of speakers and you, I would request the proceedings to be initiated, and before that, I request Professor Banerjee to have a few introductory remarks, after which the technical session can start. Over to Professor Prabir Banerjee, please.
And thank you, Dr. Santanu. This is a nice, the effort from your group, and I think it will be very much helpful because the topic it is chosen like chronic hepatitis B, particularly the viral hepatitis B, and also the chronic inflammatory bowel disease disorders. These are very keystones. Much it is a very big milestones in the in the gastroenterology fraternity, and so much of development has occurred in this field, and not the less the acid peptic disease with H pylori. It is also very important because H pylori prevalence is very much high in our country. In spite of that prevalence, we have less carcinoma stomach. Mostly they are with the acid peptic disease and its complications. Now I I I I request Dr. Prateik Poddar to carry with his first presentation of chronic hepatitis B. I think he may also give a deep thing in sometimes when he discuss like acute infections, particularly that acute the hepatitis E virus and also hepatitis A virus, because it is also important in our tropical perspective. Thank you, Dr. Prateik. You can start.
Thank you, sir. Thank you for
I'll just have one comment. That is, all deliberations, I request you to have the background of emphasizing on adherence, because this is a series on adherence, treatment adherence, and as has been mentioned by Rohan, that this is the sixth in the series. There are six more to come. So I request all the learned speakers to also keep that focus on adherence. Over. Thank you very much.
Thank you, sir. Thank you so much. It is my pleasure to be here today amongst such eminent teachers, professors, Prabir sir, Santanu sir, who are guiding stones for us, who have been guiding lights for us always. And of course, my esteemed and such loved senior, Rahul da, and my loved batchmate and my friend, Shambhu. So it's my pleasure to be here. I will try to keep to the point, that is today's topic of adherence in hepatitis management. So I think this is a very important topic, and I'm very happy that you have touched upon this very specific area, which is usually missed in most meetings, conferences, and CMEs that we have for medicine. And even in gastroenterology, this topic is usually missed. In fact, the lack of studies in this area will tell you itself that this is a topic which is usually missed, but has a big implication in patients management and ultimately patients improvement. I hope everyone can see my slides. I've started my presentation. So let's start with a case which we come across frequently, unfortunately. 45-year-old female diagnosed chronic hepatitis B with elevated enzymes about 1 to 1.5 years back. When the patient was diagnosed, she was started on tenofovir, was well maintained on therapy for a year, had normal enzyme levels and no symptoms. Then suddenly the patient lost to follow-up for the last 6 months. Then the patient presented to the emergency this time with deep jaundice, nausea and vomiting. The serum enzyme levels were in the thousands, so SGPT, SGOT, 1500s, 1600s, and the total bilirubin had reached 15.7. There was mild ascites, and the INR was 2.4. And the patient progressively, gradually worsened. The history was suggestive of a sort of a subacute liver failure, and the patient gradually worsened, and the patient was listed for transplant eventually. Now, why this happened? So on taking history, the patient had stopped tenofovir as she felt she was completely asymptomatic, also felt that the cost of treatment was unnecessary. Now, the transplant cost estimate has been given to her, which is nearly 20 to 25 lakhs. And there is a high risk of mortality now and even post-transplant. So this is the cost-benefit ratio that we discuss. Now, because I'm the first speaker, I will discuss a little bit about medication adherence. Now, this is data is from the US, where 50% of patients 65 and older do not take their medications as prescribed by a doctor. 1/3 of admissions are attributable for aged patients to missed or overdoses of medications. 40% of 40% patients enter nursing homes because they're not able to take medications themselves. There's nobody to help them out. They can't do it themselves. Almost more than 1 lakh deaths per year due to complications from poor adherence. Of course, that is their data. And it is the number one problem in treating illness today. Because as according to the AHA, the American Heart Association, because even if you prescribe, the patients do not take it properly, and this results in problems. So this cascade is the issue. For every 100 prescriptions that are written, only 70 to 80% are actually picked up from the chemist shop. 35 to 40% are taken properly, and only 1/4 to 1/3 are actually retaken once the prescriptions are over. So this is a problem. This data is again from the US because of lack of data from our data from gastroenterological departments here. But this is a problem, and of course this problem will be more acute in our country. So when we talk about hepatitis, you have hepatitis A to G, but chronic hepatitis disease mainly occurs with hepatitis B and hepatitis C. Now, Hep C is completely curable in most cases. Of course, there are a few riders, but as this is a mixed audience, I will try to keep it as simple as possible. So we have newer drugs, sofosbuvir, velpatasvir, so pan-genotypic drugs, which have excellent results. There is a finite therapy, so 3 to 6 months of therapy means you completely get rid of hepatitis C in most cases. So hepatitis B, it is the only hepatitis right now, the only one which in contention, which requires long-term or even lifelong therapy, and it has a chronic disease which stays on. Now the problem with compliance and adherence is, first of all, patients talk about side effects, whether I get side effects of the drugs, and if patients do get side effects, it's easier for them to stop it. You have complexity, so some drugs to be taken before meals, some drugs to be taken after meals. So how do we take the drugs, how many times a day? And this causes the patients to lose out on medication doses. Medication, certain patients have these beliefs, and not their own beliefs, sometimes even neighbors' beliefs, relatives' beliefs, friends' beliefs, that don't take medications. Medications can harm you. Think positive and things will be fine. And this ultimately leads to problems. Forgetfulness, especially for the aged, but that's no excuse. Logistical problems, patients going to the pharmacy, picking up medications. This has been sorted to a large extent now by a lot of drugs which are now available online. You can just get it order online. The problem is even people who are not very well versed with online prescription and taking pictures of prescriptions and sending it across, they have a problem with ordering those medications. And of course, we all know healthcare costs are high and increasing day by day. Why talk about hepatitis B? Well, hepatitis B has this interesting cycle, or basically the cell synthesis cycle and its history, the way it works. So with the hepatitis B particle, when it enters the cell, it uncoats. And you can see the nucleocapsid here, which enters the cell. The core particle enters the nucleus. In the nucleus, it forms a closed circular covalent DNA, that is a CCC DNA, which forms. Now this CCC DNA is the problem, and I'll touch upon it a little later. This CCC DNA integrates with the host's genome and ultimately translates into different proteins which form the virion again, which forms the virus again, and it kind of releases and it goes into the circulation. Now this is the problem, so just keep that in mind. So there are certain markers which are there in the blood, of course. So there are certain antigens and certain antibodies, and the general public has become well versed with it because of the COVID pandemic, unfortunately. But we have the surface antigen, the envelope antigen, the core antigen. Now usually the core antigen is not detectable by most cases in normal labs, but for research purposes you can detect the core antigen, but it's not easily available and not widely available. You have antibodies, mainly the surface antibody, the E antibody and the core antibody, which you can detect very easily. And of course you can detect the surface antigen and E antigen by the serology methods. The natural history of chronic Hep B and why chronic Hep B is important is 70 to 90% have a chronic asymptomatic infection, and nearly 0.1% per year ultimately end up with hepatocellular carcinoma, death, or have to go for transplantation. This rate of transplantation is low in the country yet. 10 to 30%, nearly one fourth, I would say, have chronic Hep B, out of which 2 to 10% per year go on to have cirrhosis. So you have one third of patients ultimately ending up with cirrhosis. And in those cirrhosis patients, nearly 4% per year have decompensation, 2 to 8% per year have hepatocellular carcinoma and death. So this is the issue. And almost only 1% per year have resolution of symptoms and resolution of hepatitis B. So there's a huge chunk of patients which keep having this disease and which keep on gradually going towards severe illness and complications of chronic Hep B. So there are drugs available for hepatitis B. So you have interferons. So of course they have been used for long, and now interferons are again in vogue for Hep B treatment, and we are looking at it more interestingly. So I will touch upon that as well. So we have interferons, which have a combined antiviral and immunomodulatory effect. And you have the nucleotide analogs. We call it the nukes. So you have the old drugs, lamivudine, adofovir, now entecavir, and now tenofovir. We had TDF, now it's TAF, which is a better molecule. So tenofovir, so that is available. Alafenamide is available now, which have a direct antiviral effect. Now there are multiple levels at which we can have this antiviral drug acting to improve the patient's, to stop hepatitis B. So there are multiple areas in multiple areas of research where it's, so first entry, so they are entry inhibitors. Again, you have the molecule trafficking inhibitors, cccDNA formation inhibitors, so that is also being targeted. After that, you have the transcription and translation, which is being affected. So you have RNA interferons acting at multiple levels actually. So nucleocapsid assembly modulators, polymerase inhibitors, cyclophilin inhibitors, and secretion inhibitors. So there are multiple levels which are potential for drug therapy. Of course, we do not have the drugs yet. They are under research. So you have a lot of drugs which are under research. So PEG interferon again is being re-researched for better therapy. So it was always there, and we were actually, manufacturing had stopped in the middle because there was no demand. But we are after the Hep B manufacturers the heavy drug manufacturers to increase PEG interferon because they have been found to have good results. Of course, Minicludex B, one of the most potential drugs, so which is the viral entry inhibitors. Again, other drugs are also in the pipeline and they are being tested currently. Now, the goals of hepatitis B treatment are to prevent these complications, ultimately prevent cirrhosis, liver failure, carcinoma, and Hep B related death. So that is what we want. And it's difficult to just measure because it's a chronic disease to measure exactly what level we are at and how we are preventing it. So we have certain surrogate markers used to measure the efficacy of treatment. So we use liver enzymes, we use fibroscan elastographies, DNA levels, other serological markers. There's fibrotest and APRI and so many things which are there, which helps us find out what state the liver is in, what level the hepatitis B is in, and how we are going to improve it. Now, unfortunately, why adherence is important. You see, in all the drugs, so this is a general idea for the drugs which are using. So there's entecavir, TDF means tenofovir diproxyl fumarate, TAF is tenofovir alafenamide, the newer variety of tenofovir, and PEG interferon. If you would see, at around 1 year or so, undetectable DNA is seen in around 60%, 70% of patients who are on nucleoside analogs. PEG interferon is only 25%. HbSAg loss. Now, why HbSAg loss? Like I mentioned, the surface antigen is basically manufactured by the virion. So it's a surrogate marker which tells us what kind of replication is happening of the virus inside the body. So the surface antigen titer is very important, and the loss of surface antigen will tell you, yes, there's a good chance the patient is towards cure or has been cured, and the loss is only 2% to 3% or even 1% at 1 year of follow-up. During extended treatment, even with extended therapy, you would see, maybe 72 weeks or even more, even with 5 to 10 years, only 10% of loss is the maximum you get of HbSAg. And this is a problem. And especially in these patients, this HbSAg follow-up, when you follow up, this is a problem because This loss, until this happens, we cannot call the patient cured. Even after that, of course, is a question mark. But at least until HbA1c loss happens, it's very difficult to call the patient cured, and therapy has to be given. So, like the many-headed hydra, of lore, we cut one head and two grows in its place. This is the problem with hepatitis B. Why hepatitis B is a problem is all because of this cccDNA. So the cccDNA, it goes into the nucleus and it integrates with the genome, and it has the ability to self-replenish. Now this cccDNA, the moment it starts manufacturing and replicating, until this happens, you have to remove the hepatocyte itself if you actually want to remove this DNA component. And because the chronic Hep B infection, the immune response is very weak. It's a mild gradual immune response. So you do not actually clear the infection and virus when this happens. And it persists in the liver of persons who have recovered from acute Hep B infection with HbA1c to hepatitis surface antibody seroconversion. Even patients who have seroconverted, we have found some cccDNA fragments and strains to be there inside the patient's liver. The nucleoside analogs, the drugs which are mainly used, the oral drugs, they mainly are working in the pre-genomic RNA and synthesis of HBV DNA in the cytoplasm. There is no direct effect on the cccDNA. So work has been going on, but the current drugs don't work there. So the drug is just working until there is manufacture of the virion. The drug is not working. The interferon, of course, has both antiviral and immunomodulatory activities. It may enhance cccDNA degradation and some kind of genetic modification as well, epigenetic modification as well. But again, the HbA1c loss with or without therapy is maximum 1% per year. So this is the problem, because even interferons are not completely effective, and you can see the data. I showed you the data there, and this remains the problem with Hep B therapy because there is no defined cure yet, and this remains an issue. And once the patient's HbA1c loss actually occurs, the risk of adverse events and clinical outcomes is improved. So risk of adverse events comes down and the patient's outcomes improve. Now, in previous years, we used lamivudine, which had a very high drug resistance, so around 70% after 5 years. So when entecavir came into work, of course, this came down to less than 1% after 5 years of continued therapy. And even after 8 years with tenofovir, less than 1% was the resistance, and that was mainly resistance which was in vitro, and in vivo we found that hardly we used to find resistance. But patients who were lamivudine exposed, this used to go up. So for patients who were lamivudine exposed, this resistance was nearly 50% for entecavir. So antiviral treatment is very important because it has been shown to improve liver histology. So the moment a patient stops a drug and gives a gap and then starts to restart, there is a risk of resistance that we are faced with. So this is another thing which we are dealing with, and that is why adherence is very, very important for our patients. After 240 weeks, that is around 5 years of tenofovir, 87% had decreased inflammation and 52% had decreased fibrosis. And 74% patients in a study who had cirrhosis had no longer had cirrhosis after long-term therapy with TDF. So the important thing is this drug therapy and the compliance of drug therapy has implications in multiple areas, not just for prevention of resistance, for prevention of Hep B manufacturing, that is Hep B replication, but also it improves liver histology in the long run. So this is something which we have to look at, because this has an implication in long-term patients' management and mortality as well as morbidity. So what are the consequences of missed therapy? Hep B flare. So there is Hep B flare, the enzymes become very high, which has a high morbidity and mortality. The patients can develop ALF, which is acute liver failure. There can be gradual subacute liver failure, which has very poor prognosis. Of course, patients who have chronic liver disease, cirrhosis, underlying cirrhosis, they go on to have acute and chronic liver failure if there is a flare of Hep B. And ultimately, even if they don't develop a flare, the disease progresses. And I'm getting more and more patients who have liver cancers now. And you have this liver cancer, HCC increases to significant effect when there is progression of fibrosis. So what are the challenges in compliance with drug therapy of hepatitis B? So one is the cost of therapy. Of course, cost has come down in recent years with all the drug therapy which is available, increased manufacturing, increased competition in the market. So now the cost is around 800 to 1,000 rupees per month. That's the cost for about tenofovir or entecavir 800 to 1400 depending on the company and the brand. You have to use the medication daily. So some patients have an issue with using the medication daily, and they don't want to take the medication daily. The benefit, of course, the plus point with hepatitis B medication is it is only once daily. So that is something which they should understand, and there are hardly any side effects. Still, patients have this daily use of medication and they don't want to do that. So a lot of patients come to me and tell me, "So I cannot take the medication. Do I need to take it daily?" Of course, the next is lifelong therapy. And this is a problem because as we saw, HbCAg loss occurs very in a very small amount of patients and after very long. So therapy is long term and especially lifelong in most patients once they start a drug. And this is a problem because patients always, anybody would want a defined quantum of therapy. They would want therapy for maybe a month, 6 months, a year, 2 years. But when it goes beyond that, that is the point where patients, they say that, "Sir, we cannot take that therapy for how long? And how long are we expected to take that therapy?" So they always come back to me and ask, "Sir, do I have to keep taking it?" And I always have to tell them, "No, you have to keep taking it." The other point is insight and knowledge about the disease. So unless we discuss with our patients, especially with hepatitis B, it's very difficult. We have to impress on them the understanding that this is a chronic disease. Unless you take the drug therapy lifelong, you will develop complications, and those complications can be life-threatening. So you have to realize this drug is protecting you. So because of this, the last point, that is asymptomatic nature of chronic illness. Now, because Hep B is chronic until you understand that it has come with a flare or come with HCC or come with frank cirrhosis with decompensation, this asymptomatic nature makes the patient complacent. They feel that as long as they're not having any symptoms, why should I take this drug? And why should I keep taking this drug, even if I started? And this is a silent killer, just like hypertension and just like any other disease which is a silent killer. Again, chronic Hep B is a silent killer until it speaks for itself. So a few studies on adherence in chronic Hep B. Here we can see, so this investigated adherence to entecavir. So 100 patients were studied. 70% showed good adherence. So this data is mainly from Europe. And the poor adherence was mainly seen who were patients who were significantly younger and more indifferent attitudes. So of course, there's a better literacy rate there, and economic rates are a little better. So for them, this was the issue which was found. Again, in India, the study was done. So in Indore, so this is a very small study, only 24 patients. So they were using oral drugs for around 6 months, more than 6 months, and the adherence rate was 2/3. So you have to realize 1/3 of patients did not take therapy as advised. Now, compliance was mainly better in the upper and upper middle income groups, in those taking the single medicines. The reason for missing medications, 90% was forgetfulness, 70% was the cost, 60% because they felt that we cannot take so many drugs because they were taking other medications as well for other things. They said 1 or 2 drugs can stop. So for them, drugs for diabetes and hypothyroid can continue, but not the entecavir or not the tenofovir. They were not feeling better with the drug, so they felt that because they were taking the drug, but there was no difference in their symptoms, and there was no difference at all. So they said, "Why should I take the drug?" Like I mentioned, asymptomatic nature of illness. And because their daily routine changed, they stopped the drug. Some reported few side effects, now questionable side effects for entecavir or tenofovir. And 30% of patients stopped the drug and missed the medications because there was lack of awareness that medicine has to be taken daily. 50%, and this is something which we should be ashamed of, but half of the patients revealed that they had not been counseled regarding the duration, side effects, benefits, and the cost of treatment. So this is an issue where we need to realize that even counseling the patients properly will make sure half of the patients actually understand better what they are dealing with. But this 2 studies again, one from Wisconsin in the US and another from Australia, they reported adherence rates of 55% and 66% only. And mainly the issue was forgetfulness. So drug fatigue, because they were taking it for a long time. They just fatigued on the drug. They said, "We will not take it anymore." They lost motivation and became complacent. Now, another link to Wuhan, this study on Hep B, where 16.5% patients only had high adherence, 32% patients had medium adherence, and 50%, nearly half of the patients, had poor adherence. And the main common reasons were the expense, forgetfulness, They had a worry about potential. Remember, this is not actual side effects, but a worry about side effects which make them stop the drug or not take the drug in around 20% of patients, and did not want others to know. So there was a stigma as well. They do not want others to know about medication usage, that they are taking drugs for Hep B. So it has that stigma in 20% of patients, and around 15% of patients just ran out of the first dose and they did not refill it again. So this study from Wuhan also shows how bad the situation is. And I believe in our country as well, if we do larger studies, we would have something like of the sort, because we are also a developing economy, just like China. So what are the answers to this? Is it counseling? I think it's counseling, and we need more counseling, because I think talking with the patient will benefit. Their questions need to be answered about when to start the drug, how long to take the drug, and the side effects of not taking the drug, and we must spend time with them. So counseling and more counseling is the first step. Cost reduction is the next step. I think if it comes down, because our country, it's difficult. We are sitting here and talking in a place which is an urban center, but as you go into the peripheries, you will find even a cost of 1,800 rupees a month does matter to the patient. Monthly reminders, frequent messages about taking drug therapy will make a difference. Certain aids to reduce memory dependence. So you now have phones, you can put alarms. So you can ask the patient to put alarms, do that. And awareness and removal of stigma is important for these. So you have certain things, technologically improved things which are available in the market. So you have phone apps. So you have markers which when you open, the phone will give you a marker that yes, your drug has been taken. So you have certain pill bottles which start having an alarm. If you're not taking the drug, it will light up, and then you take the drug, the light will switch off. And you also have certain chips which can be embedded, which are now being embedded in certain drugs, mainly expensive drugs. And you can put in it's basically a sticking pad. It's a tracker, which when the drug goes in, it gives you an alarm that the drug has been taken. So if you miss it, that alarm is missed and it gives you a notification. Of course, these are again expensive items, and I'm not sure how long and when they will be available in our country and for how many percent of the population, because I think it's only for the people who are in the rich urban centers. From our experience, there is an unpublished data from Maharashtra when I was studying there and we were working on it. The median intake of hepatitis B drug was only 14 months in rural Maharashtra and semi-urban Maharashtra. Only 14 months. So can you imagine a patient who was supposed to take lifelong therapy, they ultimately stop therapy in 14 months. And this is a problem in centers because Hep B then comes with a lot of complications. So to summarize, I think chronic Hep B needs long-term treatment till we wait for better drugs, and we need maybe lifelong therapy. Poor adherence can be life-threatening, like I mentioned. Acute liver failure, subacute liver failure, hepatitis B flare, and ACLF. The main key is counseling and follow-up. For it causes better adherence, and the cost needs to be controlled. We now have the National Viral Hepatitis Control Program, the NVHCP. Is that the answer? Because just like we had for the DOTS program, the DOTS RNTCP program, can we improve compliance of our patients of hepatitis B and of course hepatitis C with the defined therapy? So can we improve compliance with this national program? This has to be seen, but I believe that could be one answer where you can completely follow up patients on monthly intervals and the drug is given to the patient, just like for DOTS program. And we ultimately have better compliance in our patients who are on therapy. Thank you so much for listening to me. I think we can conquer Hep B properly if we give the right drug and with the right compliance and adherence to therapy. Thank you so much.
Thank you, Dr. Prateik, for a good coverage. And we listened, seriously in this case. Hepatitis B is is a unique virus, and it's a unique problem for India, the third world country. The only answer was vaccination, but appropriately it has not been vaccinated the whole population. That's why we are suffering. And now you see the COVID is there, we are vaccinating like anything. We could have do that. Probably because hepatitis B, you go to USA, there is no hepatitis B. No, only hepatitis C backlog are there. Because when it was there, 1989, before 89, they have transport blood, everything, blood product, and that hepatitis C is there. But after the invention of this hepatitis C, it was not there. There is no one single case because this is the backlog for the, already they have cleared the backlog of, liver transplant, everything, chronic liver disease. But the problem is the Southeast Asia, hepatitis B, and this is China, other thing. And hepatitis B surface antigen is never clear in these Asian countries. Because if you give the data from the Western countries, they can have clearance. And this virus is very unique because it is a CCC DNA, close covalent circular DNA. It has got no telomere. So you cannot invade it, you can destroy it. You can erase it. And you go to the hepatitis B, the genome of the human, and it just fix it there, and they do that, this thing. And this is main problem. It will be in the long run is hepatocellular carcinoma. A good number of cases they can have hepatocellular carcinoma, even they clear. There is serological, clearance is there, like anti-HB DNA or anti-HBC regime. Even then, they stay in the nucleus. So there will be problem for hepatocellular carcinoma. That is the problem. This is the load of Indian population, because as they are aging and they are living, that may be a problem. Okay, but you can stop this thing, other thing, that fatty liver, you can avoid fatty liver, alcohol, other factors. Okay, or other hepatitis C, chronic hepatitis C, if you can avoid, then there will be less chance of hepatocellular carcinoma. So I think this is, Annalok has done a lot of work in USA, but in USA, hepatitis B is not available. It is not available there. You cannot see a case of, because some of the Asian patients, they go there for a liver transplant, but they are the hepatitis B. But with the American population, those who are American citizens, only some of the Asians, they are hepatitis B positive. That's the problem. So it is a nice thing you have done. So the main problem, hepatocellular carcinoma, and also the vaccination you have done. We have already covered, possibly in India, we have already covered. This is the only answer, because you see that now COVID, they are taking, all of you are taking virus, but this is a vaccine which prevent cancer. Always I say to my patients, you have to check the family of hepatitis B, for hepatitis, if there is hepatitis sufficient positive or not. If they are not, even at this age also, we just suggest go for vaccination. Go for vaccination. Even with age, immunogenicity comes down. Even then, you have to do that. This is a very vital job for a family where there is a chronic hepatitis B, 1 or 2 cases. Okay, thank you very much. Santanu, you want to comment?
Yeah, it is an excellent presentation, and particularly keeping the focus on the adherence. And you have very nicely explained how important adherence is. And yes, of course, there is a need for generating data in India too. Most of the references are actually from China or other parts of the world. We need to also, I don't know.
Yes, go on.
Am I audible?
Yeah.
I think we need to also generate data in India itself, data on adherence. So that I don't know whether in India we have a national registry of hepatitis patients, or for that matter, whether we have a registry in Kolkata, hepatitis B patients. And then only one can think of doing this kind of a study where a disease which requires lifelong therapy. And it is really alarming to learn that in one series, at least what Dr. Prateik has mentioned in Maharashtra, that they have shown that the median or the mean duration of therapy is people are continuing till 14 months and then stopping it for whatever reasons. So it is really alarming. So you have underscored the importance of treatment adherence. Yes, cost might be an important issue, but then in many cases it is the spirit or it is the lack of understanding that may be also very, very important. Thank you very much. You have done really justice to the topic, and time permitting, we can come back for some more questions to be discussed. With this, I would request, I think next speaker is Dr. Rahul Jain. Yes, Dr. Rahul Jain, we have heard you earlier also, an excellent speaker. Always nice to listen to you, Dr. Rahul. and you will be speaking on peptic ulcer diseases and the importance of adherence in peptic ulcer diseases, long-term therapy in peptic ulcer disease. Over to Dr. Rahul, please. Thank you.
Many thanks to our respected Santanu sir and Prabir sir, and I would also like to thank my dear friend Dr. Shambo, and of course, coming after the excellent speech of Dr. Prateik Poddar, it's a pleasure to be here and speak to all of you today. Now, I am, because I happen to be an internist, I come across people who are suffering from many kinds of diseases of all organ systems. And peptic ulcer disease is something which we see very, very often in our outpatient departments. Can I have the next slide, please? So, peptic ulcer is a defect in the gastric or duodenal wall that extends through the muscularis mucosa into the deeper layers of the wall. And our basic primary target to treat peptic ulcer will be to treat the underlying etiology and eradication of Helicobacter pylori. And we have seen that there is higher healing rates in patients with the duodenal and gastric ulcers with the eradication of H. pylori compared to only using proton pump inhibitor or H2 blocker. Now, the important thing that I would like to would like to emphasize here is that most of the cases of peptic ulcer disease have can be treated simply by using proton pump inhibitors and by eradicating H. pylori. Some of these peptic ulcer diseases can be recalcitrant, and especially persons who are taking long-term drugs such as corticosteroids, people who are taking medications like bisphosphonates, people who are taking painkillers, and various other rare and unusual conditions, they can also have a lot of peptic ulcer disease. So, other than that, remission rates for gastric and duodenal ulcers when H. pylori is treated is 97 and 98%. When you compare and contrast that with only using proton pump inhibitors, in which you will only get a 61 to 65% and 65% healing in gastric and duodenal ulcers, respectively, when only proton pump inhibitors are used. The important thing here is what Dr. Prateik was mentioning was that the average, he mentioned a particular statistic that 14 months was the average duration during which people would take hepatitis B medications. The problem we face as clinicians, as internists, is something of excess. And it's important that everyone should realize that people should de-prescribe NSAIDs when and where possible. And even in the case of peptic ulcer disease, I make a humble appeal to people who are prescribing proton pump inhibitors with at the drop of a hat is to de-prescribe and slowly taper off proton pump inhibitors because they are, one of the most abused drugs. I feel. In fact, the problem we have as internists is the problem of plenty. It's not that people stop. Even when we ask people to stop proton pump inhibitors and not pop them up like a lozenge or a toffee, they keep taking proton pump inhibitors. And the problem which compare and contrasted with the problem of, say, chronic disease like diabetes or high blood pressure or chronic hepatitis B, which cannot be cured but can only be ameliorated by giving chronic therapy. The problem with acid peptic disease, GERD, the problem is that people keep taking these drugs, often to disastrous results in the body. Can I have the next slide, please? So, like I mentioned, non-steroidal, non-NSAID, and non-H. pylori peptic ulcer diseases can be due to other drugs as well, which I had briefly mentioned. Paracetamol is surprisingly a drug which makes it to the list. It's not as innocuous as we think it is, but very, very small percent of patients can have peptic ulcers because of paracetamol as well. Bisphosphonates, steroids,
clopidogrel, sirolimus, spironolactone, and the selective serotonin reuptake inhibitors, especially venlafaxine, 5-fluorouracil, then the certain bugs such as Helicobacter heilmanni, herpes simplex virus 1, cytomegalovirus, Epstein-Barr virus, Candida, mucormycosis. Of course, mucormycosis is very much in the vogue now. Then there are certain obstructive congenital duodenal webs, hypertrophic pyloric stenosis, annular pancreas, foreign bodies, especially in people with psychiatric disturbances, trichotillomania, we call them trichobezoars, can be seen. We've seen a couple of cases of trichobezoars in endoscopy. Recently, we've also seen very frequently in our hospital, we do a lot of gastric bypass surgeries in the hospital I practice in. So peptic ulcers are common there as well, ruined by gastric bypass. Even mini gastric bypass can present with peptic ulcer disease. Gastrinomas, Zollinger-Ellison syndrome, mastocytosis, myeloproliferative disease. I must confess I don't come across these cases too much. Then there are cases like sarcoidosis, Crohn's, IgG4 disease, Wegener's, and stress ulcers in the ICU. Stress ulcer bleeding is something we see a lot, especially after head injury, after massive intraventricular hemorrhages. We see a lot of patients who present on the third, fourth, fifth day with hematemesis and melena. And when we scope them, we see that there is stress ulcers in the stomach or duodenum. So we do get these cases, and of course, why forget the long-term use of proton pump inhibitors, which causes a hypersecretory duodenal ulcer. And I suspect we are going to see more and more of these cases as the lowly, PAN 40 or Omes becomes it's already over-the-counter medication. As more and more of these drugs are overused and misused, we are going to get more and more of these cases. Can I have the next slide, please? So, first line therapies for H pylori, there are a number of different protocols. Bismuth quadruple, we don't use bismuth here at all, but what we do use in peptic ulcer disease is the standard proton pump inhibitor, whether it's a lansoprazole or a pantoprazole or an omeprazole, with a clarithromycin and amoxicillin. Clarithromycin in the dose of 500 twice a day for 14 days, and amoxicillin twice daily for 14 days, concomitant with clarithromycin and PPI double dose. And if the person does not tolerate amoxicillin, then we give metronidazole thrice a day along with clarithromycin and PPI for 14 days. So this is the basic triple therapy, which is used very, very frequently. At least I use a lot, and to good results. The next slide, please. So as we know the actions of anti-ulcer medications, we have the surface-acting antacids. We have the H2 receptor blockers, where the H2 blockers work, and of course the hydrogen potassium ATPase pump, where the proton pump inhibitors work. And these are the basic sites where these drugs are being used. Antacids are also available over the counter. And I'm afraid a lot of people, especially in our culinary, who indulge in a lot of culinary adventures, they often pop in, they keep on the bedside. I've seen many people who keep these bottles of Digene and Gelusil, and they always have antacids readily available at hand, and are taking in small aliquots of antacids, surface-acting antacids, whenever they require. So I was mentioning the problem here is the problem of plenty. So where do we draw a line? The problem with the compliance is the over-compliance, should I say, or even when it's a particular medicine is de-prescribed, people continue it, and often to disastrous effects, which I will come to in my next few slides. But people who do not take, for example, people who have proton pump inhibitors and don't take, for example, the H pylori medication because of cost, clarithromycin being an expensive medicine. Metronidazole or tinidazole can have an awfully bad metallic taste. And of course, amoxicillin can present with the diarrhea. So because of cost and diarrhea and because of bad taste, some people can, there will be a group of people who will not take these medications, and they can end up with all sorts of problems such as duodenal strictures and perforations, hematemesis, melena, and of course we have the plain variety of patients who are presenting to us simply with chronic anemia, unexplained anemia or heartburn. Some people are presenting with dyspepsia. So in addition to the loss of the quality of life, people are also presenting with, in the case of people who are not adhering to the, or not complying with the prescription of the triple therapy or the quadruple therapy of pantoprazole with or a lansoprazole or an omeprazole with a clarithromycin and amoxicillin or metronidazole. So, and then I talked about the long-term abuse. I prefer to use the word abuse of proton pump inhibitors, which is a pandemic. It's almost worse than COVID in our country. Next slide, please. The problem is that these drugs are have a primary and a secondary pathway, and a number of cytochrome enzymes are involved in the hepatic metabolism of these particular drugs, and they are supposed to be taken in a for a limited amount of time for a specific reason. And the moment any of these drugs are popped in like a Poppins or a toffee, then then we have the problem, because long-term intake of these drugs can lead to a lot of deleterious side effects and drug interactions, which can very adversely impact people. A number of reasons why people I have a lot of patients who have diabetes, they have high cholesterol, they have blood pressure. Some have all three, and some people have various combinations of, three anti-hyperglycemics, one antihypertensive or two antihypertensives, one dyslipidemic, one pantoprazole, and all sorts of medications are going on. And many a time they come back, and I've seen more often than not, they'll stop their cholesterol medication or they'll stop their blood pressure medication, but they continue to take that pantoprazole and that omeprazole. I don't know how common this is with my esteemed speakers in this co-panel, but I find that exceedingly common that people will stop medications, will go for all sorts of herbal and alternative therapies, but will continue to take the PPI. It's something which baffles me as a physician. What is it which is so addicting about these proton pump inhibitors that people keep taking perennially for weeks, months, years, and even decades? I suppose it gives a lot of people confidence to take alcohol whenever they want to eat rich food, biryani at the drop of a hat, and not feel the um pangs of eating such a rich food. People can eat at all odd hours. There are students, there are doctors I know who are completely addicted to drugs like pantoprazole and omeprazole because of our irregular eating habits. And that leads to a lot of problems. Can I have the next slide, please? So I was talking about some of the drug interactions which happen with the proton pump inhibitors. Warfarin is a drug which has an interaction with commonly used PPIs. Diazepam is another drug in which the T half is increased very significantly because of decreased clearance. Phenytoin can have an increased T half, and phenytoin, as you know, is a toxic drug if it goes beyond the therapeutic window. Theophylline is another drug in which the area under the curve is increased by 10%. Digoxin, now these are very toxic drugs, and there's a specific dose in which they are given, and if they either exceed that or fall below the margin, then they're not supposed to be doing what they should be doing, then they cause more adverse reactions than to help ameliorate the condition for which they were initially prescribed. Again, carbamazepine is a drug which has interaction with a lot of these proton pump inhibitors, specifically omeprazole. And over here, I would say pantoprazole is a drug which perhaps scores better than the other drugs. Can I have the next slide, please? Okay, we'll let this slide pass. It's very, very small. You'll not be able to read. So, adverse effects of long-term PPIs. We see a lot of adverse effects of long-term PPIs. Now, we are seeing more and more cases of C. difficile infection in the hospital. And one thing which I found common with, other than antibiotic-associated diarrhea, is long-term hospitalization and many antibiotic therapies given to patients. Is one thing which I've seen is the long-term use of proton pump inhibitors. So Clostridium infection is purportedly more with the long-term use of PPIs, and Salmonella and Campylobacter we have classically seen in that typhoid is a drug. Typhoid is a disease which happens when there is in excess when there is achlorhydria or hypochlorhydria. Microscopic colitis, hypergastronemia, which I talked about because of the excess duration of long-term use of, or should I say, long-term abuse of proton pump inhibitors is these are big compliance issues. Chronic atrophic gastritis, intestinal colonization of multi-drug resistant organisms. That's not a very pleasant thing to happen, because you're inviting all kinds of bugs in your body because of the protective loss of the acid secretion in the stomach, and growth of microbes which produce extended spectrum beta lactamases, ESBLs, carbapenemases, or plasmid mediated AMP-C beta lactamases, vancomycin resistant enterococci. So these are again these are dangerous things to have, especially in the hospital setting. One you might come across. In fact, I've come across people who get urinary tract infections, chest infections in the community. They come with all sorts of resistant bugs. One of the problems is the easy availability of antibiotics over the counter. Go to any chemist shop, and you will find that you can easily avail of these antibiotics, 2 tablets, 3 tablets, 4 tablets, whatever you want you can buy. Don't need to buy strips. And the other is, of course, I strongly suspect that long-term use of PPIs have a role to play in this. We also see very, increasingly it's become common that magnesium malabsorption. I've seen, we routinely measure now, whenever a patient walks into the hospital, we are routinely measuring magnesium. The other epidemic, which is, sort of running parallelly with PPI abuse, is that of the COVID, where people are, just popping zinc like it's nobody's business. And PPI and zinc, it's a deadly combination. Most patients who are coming in with the magnesium levels of 1.3, 1.2, 1.4. That's very dangerous. Lack of calcium absorption, which is going to lead to, fractures and weak bones, osteomalacia, depending on what age the patient is in. Vitamin B12 malabsorption, iron malabsorption. Now, all these things are adverse effects of long-term PPIs, which we despite being de-prescribed or prescribed for a small period of time, people continue to take, and these are not very great things to to happen. The other problem that I find with the use of proton pump inhibitors is that the friendly doctor, instead of giving a simple single drug like pantoprazole or esomeprazole, adds the deadly duo of you have all these drugs which end with either D or L. That's a disaster, because I have seen in my practice, I have seen approximately 10 patients with permanent extrapyramidal symptoms. There was this elderly lady. She used to come to me for amar gas hocche, amar and she refused to do an endoscopy. She would simply refuse to do an endoscopy. I kept telling her that I think you have peptic ulcer disease, you have some symptoms of gastroesophageal reflux. Please do a endoscopy. She refused to, and she went to her neighborhood doctor, who prescribed her a particular brand of pantoprazole and levosulpiride combination. Now this is a drug which really scares me. I don't know what the view of my speakers is. She took it in a twice daily dose for 6 months, and guess what? She comes to my chamber. This elderly, well-behaved lady, Muslim lady wearing a burqa, and she opens her, sort of head covering, and she's winking. It's very, very embarrassing. I said, what happened to you? He said, Ami Janina. And it's this kind of facial, tardive dyskinesias, orofacial dyskinesias. People come with frank Parkinson's disease after the intake of levosulpiride. Even domperidone, purportedly some domperidone finds its way across the blood-brain barrier and can predispose to extrapyramidal syndromes, extrapyramidal side effects. So these are, any drug is unless it's given for a rational indication. These are issues, and people don't stop taking them. What Dr. Prateik, the problem he faced, I faced the opposite problem. These are compliance issues. These are, integral issues that we as physicians have to realize when to stop and to communicate. I liked how Dr. Prateik Poddar stressed on the fact that communicate, counsel, communicate, counsel. I like that approach, because no matter how much we communicate and how much we counsel, it is up to the patients to understand and take drugs which are prescribed to them, and to stop when they are asked to stop. Can I have the next slide, please? So there is a lot of, I put a lot of question marks here. Kidney disease is something which can happen with long-term use of proton pump inhibitors. Some of that may be due to secondary magnesium deficiency. Drug-induced lupus is being talked about with the long-term use of PPIs. There have been some reports, unsubstantiated, unverified in big studies about increased risk of COVID-19 infections. There are also studies which talk about increased risk of dementia, of different kinds of pneumonia, and increased all-cause mortality with the long-term use of proton pump inhibitors. The next slide, please. So we talked about how the proton pump inhibitors, which are the mainstays of treatment of peptic ulcer disease, are metabolized by the hepatic cytochrome P450 enzymes. It's CYP2C19 having the dominant role. So some people can have these gene mutations which can have, and they can have higher plasma PPI levels in homozygous individuals, and it can become a major target for interaction with many drugs, including warfarin, diazepam, clopidogrel, and phenytoin. And there is decreased activation of clopidogrel when used in conjunction with omeprazole due to shared hepatic cytochrome P450 mediated metabolism. Some HIV protease inhibitors are contraindicated with PPI, such as rilpivirine. Atazanavir should not be used in patients who are requiring a dose more than 20 milligram or equivalent of omeprazole daily. And methotrexate is another. You have to, we don't have the means and whereabouts to monitor methotrexate levels readily available in our country. And co-administration of PPIs with high-dose methotrexate appears to be related to higher levels of methotrexate in the blood, and potentially may lead to liver damage, bone marrow suppression, infections, and what have you. I have seen many patients of who are receiving methotrexate, for example, for psoriasis or for different kinds of other, illnesses, in which they come in with the total white cell counts of 400, 500, 10%, 5% neutrophils. Needless to say, a high percentage, very high percentage of these patients end up losing their lives or they come with irreversible liver damage. Now, obviously, we don't have gene studies whereby we can, quantify how much. And guess what? Most patients who are on any long-term, especially painkiller medications, are almost always. If I think our senior teachers like Prabir sir and Santanu sir can do studies about the co-prescription, or should I say, the irrational co-prescription of and continued abuse of PPIs, which I cannot overemphasize in the time which has been given to me. And perhaps we can get more data on the same. The next slide, please. Okay, I think that brings me to the end of my talk. And I would love to face questions at the end of the program. Thank you very much.
Dr. Rahul, for your nice presentation with full of information and empathy for the patients and pain for the patients. This how they are taking these drugs, other things. But very important, Peptic ulcer disease. So for the H pylori, when it was that discovered, it was from then it was very important because the whole scenario has changed after H pylori. Because we should know that there are Peptic ulcer means to say that there is a acid peptic disease, there is a piece. It may be a acute entity, like what you said with NSID or with ischemic because of cardiovascular decompensation in a IT patient, there may be ulcers or something like Cushing ulcers, other thing. And another entity there where there is a called chronic acid peptic diathesis that is influenced by H pylori. Okay, so it is very important, the H pylori. But the H pylori in our country, a lot of people, the prevalence of H pylori in a point, if you take it, it is very high. Because, you know why? Because this is for our personal hygiene. Because the domestic help comes to us, they come from the slum. And we don't use any paper towel, during our after the in the bathroom. And if then they just give this thing to you people, if you take even a good is a better or this water and other thing, they give it when they wash utensils, other things. So they give us these bacteria. And if you give PPI to indiscriminately in these cases, as there is acid knockout, and you taking all these bacteria, so it will propagate like anything. And ultimately, what is happening? You take PPI, and there is a small bacterial overgrowth. This is a vicious cycle. And even H pylori also is cycling like that. So that's why you have to keep it in mind. And another thing that we do a lot of endoscopies. We do routinely you can do H pylori by the rapid usage test. And if you get this H pylori positive, practically to be rational, you should not treat H pylori because this will not do anything. Because when you treat H pylori, when you see on endoscopy there is an ulcer, there is an inflammation, and other things are there. PRT has no relation with the H pylori. Then you can take a biopsy there. If it is positive, you treat this person. Otherwise, only H pylori does not mean anything. You treat this case, again they will have infected. They will have infection with the H pylori again because their personal hygiene at this system. What I have said. But when H pylori is positive, and there is a family cancer syndrome, mind it. In this family, these patients, there is a family cancer syndrome. He is prone to have malignancy. You treat this GI system, like carcinoma cervix, like anything, then you treat it. And you have nicely highlighted the acid knockout well also, because intrinsic factor it is not sweet if there is no acid. These are the problems. Ultimately there will be small bowel bacterial overgrowth, and a lot of things can happen. And it has been seen in the literature and in this thing is that long-term PPI can give rise to chronic kidney disease. Chronic renal failure. Long-term PPI without any without any justification, you can have more heart infarction, more severe. These are the things you have to think of this. Better if it is there. I think ST blocker, it is better. Even you can take antacid, but not that a bottle of antacid where it will cause osmotic diarrhea or constipation, something like that. Not like that. You can take that. It is better. If they take this thing and they go for endoscopy, particularly young age group, they have to do it for endoscopy or GI bleed. You have to go for endoscopy. And then young patients, they have this patient, if expert is there, I said, if they treat this. Yeah.
Well, it was again, as usual, a very excellent presentation. What I liked is particularly the emphasis on the proton pump inhibitors, which has really become a menace over the last few decades. The use, misuse, and overuse of proton pump inhibitors. I wonder, out of the total usage of proton pump inhibitors in the country, what percentage are actually under prescription, number one, and second, to what extent such prescribed proton pump inhibitor use is being regularly monitored. On the other hand, we need to also highlight the issue Dr. Rahul has pointed out, that on one hand, when Dr. Prateik mentioned about the problem of not adhering to the treatment prescribed, on this side there is a problem of plenty, that you really don't need it and you keep on taking it. Okay, but if we go back to the definition of adherence, we'll find that adherence is actually the extent to which the patients, they are sticking to the recommendation by the prescriber. Okay, they are actually following the advices of the prescriber. So anything which is departing from that is actually lack of adherence. So even if you are taking it more than what you are expected to and what you are advised to, it is also an adherence problem by definition. This is one important aspect to underscore, and that is the reason why we, by design and by intention, we have kept both these two scenarios. On one hand, it is hepatitis B, when people are, for whatever reasons, they are unable to, or they are not actually taking their medicines for the entire period when they are actually expected to for lifelong treatment. On the other hand, proton pump inhibitors, okay, prescribed or not prescribed, a vast majority of the people, they are taking proton pump inhibitors just like that. Okay, just step in, you take your tablet strip and keep on popping the pill of proton pump inhibitors. So that's dangerous. And your point is well taken. There is a need to really do the prescription audit, and wherever it is so required, the principle of de-prescribing, we talk about prescribing, but de-prescribing is extremely important, and that should also be followed. And of course, we need to have more and more collaboration with gastroenterologists, internists, and clinical pharmacologists to actually bring rationality in the prescribing behavior and also medication usage behavior among the people. So I think you have done a wonderful job, and you have done justice to the topic, Dr. Rahul. Congratulations and thank you very much. And now we can go ahead to welcome the next speaker, Dr. Shambho Samrat Samazda, who will be again dealing with another area of gastroenterology. And that is, I think, is it okay, Dr. Shambho, you can project your screen and introduce your topic, please.
Thank you, sir. So actually, it is my real honor to share the ideas with my mentor, Professor Santanu Tripathi sir, and one eminent gastroenterologist in the city, Professor Banerjee sir. And it is really challenge to me because, and also it is very much I may say it is a proud of mine that I am sharing this after talk of my senior Dr. Rahul Jain and my friend Dr. Prateik Poddar. Actually, we all know in cricket, specifically the test match, after having two wonderful opening batsmen, sometimes we need to face night watchman. So hopefully this night watchman me will play good little bit. So let's come to the topic. Hopefully my screen is visible. Is it okay, Rohan? My screen is visible. Rohan, can you hear me?
Yes,
Hello?
it's visible. It's visible, Dr. Shaman.
Okay. So for next 15 to 20 minutes, we'll discuss about adherence to inflammatory bowel disease. And for that, we'll more focused on the different immunosuppressive agents. So this will be my flow of discussion, little bit overview of therapeutics, then coming to the adherence to therapy. What is the definition of adherence? What are the effects of non-adherence, specifically while talking about inflammatory bowel disease, and how we can improve adherence. So while talking about inflammatory disease, it is important to note that it is an immune-mediated disease, chronic in nature. We can see two broad categories of inflammatory disease. One is ulcerative colitis and another is Crohn's disease. And how it happens, in our gut, there is one T regulatory cells which mediates FOXP3 and make our immune system regular, or we can say functional, so that the food item, when it reaches gut, our gut will not act with that food item like a foreign substance. But what happens when this regulatory system becomes dysfunctional? Our mucosal immune system becomes reactive, and there will be some inappropriate innate immune sensing, which causes activation in the CD4 T cells in lamina propria, and there will be different T cell mediated mediators that come into the picture. So Th1 cell secretes interferon gamma, Th2 cells secretes interleukin 4, 5 and 13, and Th17 cells secretes interleukin 17 and 21. So while talking about disease, we need to understand the target, because if we not find the target, then we will not get our weapon, that means therapeutics. So here few important targets. Initially, in the leukocytes, the receptors on the leukocytes, the alpha 4 beta 7 integrin, which helps the leukocytes in adhesions, and that is one pathologic features of inflammatory bowel disease. Apart from that, addressins on vascular endothelium like MedCAM1, and this receptor tells us the importance or giving importance on coexisting thrombotic natures in our system while we are suffering from inflammatory bowel disease, to take care on that. And then the Th1 cytokine pathway initiated by IL-12. So we need something to reduce that expression of interleukin 12. Apart from that, interleukin 4, interleukin 23 and interleukin 6 induce the Th2 and Th17 cells. And what happens? There will be the activation of macrophages which secrete two important cytokines like TNF alpha and interleukin 6. There is one friend in our gut, that is interleukin 10 and transforming growth factor beta. If they are acting in a regulated way, they helps in by preventing inflammation. So coming to this picture, the inflammatory cascade in IBD, and what I want to give emphasis on the gut microbiota. So normally we have good gut microbiota, but due to some environmental influences, rather we can say bad influences, there will be alteration in the gut microbiota composition, and which happen to be a detrimental step in producing this inflammatory cascade by stimulating that TLR and causing activation in the dendritic cells. So that dendritic cells, there will be no regulation by the Treg cells which induce FOXP3 by deactivating that dendritic cell. And what happened then? Ultimately, there will be more Th1 and Th2 cell expression, production of different inflammatory, pro-inflammatory cytokines like interferon gamma 4, 2, 13. Here 10 means what happened? The activation of this dysregulated system causes some changes in the interleukin 10 receptor. So here the good interleukin 10 behaves like a bad interleukin 10. And apart from that, other pro-inflammatory cytokines like TNF alpha, interleukin 12, interleukin 23, which activate macrophage, and macrophage becomes activated. And they cause the mucinous layer impaired. So we have some inflammation or autoimmunity. So here also there is the focus how the other inflammatory cytokines are going to disrupt that tight junction in that epithelial cell. So there is a disruption of tight junction, there will be bad microbiota enters, so the vicious cycle of autoimmunity started. So here we can understand the friend is only Treg and FOXP3 that producing interleukin 10 and TGF beta, which helps to prevent inflammation. Otherwise, all these inflammatory cytokines like 4, 5, 13, like 1, 6, 12, 23 and TNF alpha, all those happen to be bad, or we can say enemy to our gut, and they are responsible for that alpha 4 beta 7 stimulation. Again, we should remember that is another target for different drugs which helps in leukocyte recruitment, and that perpetuates the inflammation cycle. So this is very important to understand, because after knowing the target, we can select our weapons. So this is in one slide we can say the different weapons we have, and the weapons we need to prescribe to our patient. Along with, if we know our target, we know our weapon, we can discuss this with our patients in the layman language, so that patient can understand the importance of each drug. So for biological agents, we have adalimumab, we have infliximab. They generally block that TNF alpha things. There are some leukocyte apheresis, or we can say that alpha 4 beta 7 integrin level things. So that is generally mediated by certolizumab, or sometimes that we can say the abatacept, like that. There are some inflammatory modulators like azathioprine. There is an importance of antibiotics because there are some bad microbia like Escherichia coli, they and some anaerobes, they cause some trigger to this disease. And for that, to take care of E. coli, we have ciprofloxacin. To take care of anaerobes, we have metronidazole. The other biologic agents like anti-TNF alpha, we can say that the adalimumab already we had discussed. They are generally used for ulcerative colitis. The infliximab, abatacept, adalimumab. Vaccine has some theoretical role. We need to have more studies on that. And probiotic lactobacillus has some role. Inflammatory modulators like mesalamine, they have some beneficial role in ulcerative colitis, and theoretical role of vitamin D, growth hormone, JAK3 inhibitors, naltrexons are explored in case of ulcerative colitis. Now, coming to one case, that 30-year-old Mr. AN, about 3 weeks ago, experiencing a crampy right lower quadrant abdominal pain, increase in frequency of bowel movements to 5 to 6 times per day. Abdominal pain became worse after consuming a meal and was partially relieved by defecation. There is anorexia, which is increased in nature, 8 kg weight loss, mild fever, tender abdomen, presence of occult blood in loose watery stool sample. So these are the lab results. Hematocrit is 26%, hemoglobin is 8 gram per TL, WBC count is raised, ES are raised, sigmoidoscopy, lower colon and rectal biopsy not giving any clue to any disease, stool samples negatives for Clostridium difficile and parasites. Barium minima suggests there is some presence of an edematous ileocecal valve and terminal ileum. Endoscopy suggests cobblestone appearance of the GI mucosa of the terminal ileum, which with some areas of diseased tissue separated by normal mucosa. So the diagnosis was made by gastroenterologist. It was a Crohn's disease, but while eliciting history, it was found that this particular person was suffering 5 to 6 episodes like this for last 2 years, occasionally taking antibiotics like ciprofloxacin, ornidazole fixed dose combinations, sometimes ofloxacin, ornidazole combinations, or metrogyl tablets as over-the-counter medications. One time he had visited to one physician. That physician had advised some test, but no investigations done. So this is very important because while we are talking about any disease, this is the main adherence issue happened when the patient starts ignoring his symptoms and ignoring the advices from physicians. So we need to take care of that. And now coming to the therapy in whole, these are the different types while choosing different therapies to inflammatory bowel disease patient. We have to classify. There are some classifications. We are not going in details about that. Mild variety, moderate variety, and severe disease. And for mild, we can use topical corticosteroids, antibiotics like ciprofloxacin, metronidazole, or aminosalicylates. For moderate, we can use immunomodulators, oral corticosteroids. But for severe disease, we need to biologics. And for treatment responsive ones, we need to stuck with aminosalicylates. There are some theories nowadays, and I think 2021 there is 2020 there was a guideline made by American Gastroenterology Association that using biologics from early stage, which can prevent further progression or not. So there are some guidelines are there. I am not going in details because that is not today's discussions agenda. So coming to adherence to long-term therapy, because there is we are convinced that inflammatory bowel disease is such a disease which requires long-term therapy. And now, while defining adherence, it is important to note that the extent to which a person's behavior, taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. So that is adherence. So we always use one terms compliance along with adherence, but there are some difference between adherence and compliance. While taking classes and while going to patients and taking history of them and suggesting some therapy, I remember my two professor. One is during my MBBS days, Professor Ardhendu Sinha Roy sir, and during my DM training, Professor Santanu Kumar Tripathi sir always tells us, while teaching or while seeing patient, be a coach to your patient or be a coach to your student, not a teacher or just not an advisor. So what happened in the in any game, in games like football, coach is there to help or guide the players. So we have to execute that role, and for that what is important, that agreed recommendations, this agreed terminology is important. So for adherence, agreement is important. So this is an agreement between me or we and our patient. So that when the patient is agreed to continue this, so that is the adherence. And adherence means in that there should be active participation of patient. Otherwise, there will be no adherence. But for compliance, coaching is not there. It is only to see. So there is no agreement between patient and doctor. So we always need to give emphasis or while treating our patients on adherence, not only talking about compliance. So patients' agreement to the recommendations is very important. So here the patients are active partners with health professionals in their own care. So we can involve patients in their own care. So now coming to the inflammatory bowel disease and non-adherence rate. So it has been seen in Asian IBD patients, the non-adherence becomes 20% to 30%. And among the young adults and pediatric patients, the non-adherence rate is around 17% in young adults, 5% in pediatric patients. So pediatric patients have less non-adherence, so they are more adherent. There is obvious reason for that, we all understand. And for biologics therapy, specifically the anti-TNF alpha therapy, the non-adherence rate is between 6% to 14%. So we can say, as this is very important to note, that the persons who require biologics, they have some better adherence rate. But again, this should be this is very much dependent on the context of the patient, the availability of the drugs. These are the issue, the financial things. So it is important to note the other factors also. Now coming to non-adherence in inflammatory bowel disease, what is the effect of non-adherence? So there will be increase in disease activity, more chances of relapse, loss of response to anti-TNF agent. So this is very, very unfortunate, because we know that anti-TNF agents are costly. So if this happens, loss of response, so that is very unfortunate. The non-adherence is directly correlated with higher morbidity and mortality. There is more chance of colorectal cancer in a non-adherent IBD patient. Increased health expenditure, poor quality of life, and as there is one specific index, inflammatory bowel disease disability index, that also the high disability score is correlated with poor adherence or non-adherence. So there are some other issues while talking about adherence to therapy, or we can say the immunosuppressant therapy in inflammatory bowel disease. So there are multiple drugs we already discussed. So while we are choosing ASA based therapy, our patient need to adhere to folic acid supplementation. So that is very important. Patients who are on glucocorticoid therapy, they should be adequately informed about the importance of tapering of glucocorticoid dose. While we are prescribing azathioprine, it is essential to be adhered with this practice of monitoring complete blood count and liver function test. Even with methotrexate therapy, it is important to go for testing with CBC and LFT. And sometimes the hypersensitivity pneumonitis is very common with methotrexate therapy, and we should be taken care of, and our patients investigation protocol should include to exclude hypersensitivity pneumonitis by investigations. While patients are on cyclosporine, it is obvious to adhere to check blood pressure, creatinine level, to screen for opportunistic infection, and sometimes we need prophylaxis against opportunistic infections like pneumocystitis, carinii, pneumonia, like cotrimoxazole therapy. Monoclonal antibodies are very important, and as already we had mentioned about non-adherence means there is a more chance of failure to monoclonal antibody, and one of the reason is that if we are not prescribed, or if we are not adhered to appropriate dose and frequency of monoclonal antibody, there will be increase in the development of antibodies to these monoclonal antibodies. So there are some protocols to increase the dose of this type of monoclonal antibodies and reduce the frequency of dosing, so that we can overcome to that antibodies to different monoclonal antibodies. There is a chance of lymphoma, and if we go by the side effects in the prescribing information of all monoclonal antibodies, there are chances of lymphoma. But this increase the fear among our patients. So we need to discuss this matter with our patients. We need to talk with our patients with all relevant data, whatever they can understand. Otherwise, they will not adhere to therapies like monoclonal antibodies, because they will go for internet checking. They will see this monoclonal antibody associated with lymphoma, they will stop taking it. So this is a very important thing to note, that how we can assess the risk, how we can make understand our patients about the risk and benefit of monoclonal antibodies in a balanced manner about lymphoma, incidence of lymphoma. Now talking about pregnancy and lactation, that is very important to note also, because there are some patients who left therapy, and there may be in remission phase, but again when they becomes pregnant, they will have a flare up of the disease. So we need to educate our patient that if you become pregnant, then there is a chance of recurrence, so you need some therapy. And we all know drugs like sulfasalazine, mesalamine, balsalazide, they are safe in pregnancy and lactation. So what is important when the patient is in active phase, there is symptoms, so the patient will come to the doctor, and patient will seek for advices and drugs. So the healthcare seeking behavior is there when we are symptomatic, but when our symptoms gone, So healthcare seeking behavior gone, we become non-adherent. So we need to address this issue very holistically. Otherwise, there will be problem. So now, while prescribing therapy, it is also important to measure adherence. Otherwise, whatever therapy we are prescribing, that will not act, because drug will act only if we take that. So there are some methods like direct method and indirect methods. Direct methods means measurement of levels of different metabolites. Indirect methods are there like pill count, pharmacy refill, electronic monitoring devices, and some patient self-reported questionnaires. Now coming to each portion, I will be brief in that. Like estimation of different drug metabolites, just one important molecule is azathioprine. We know that this is a steroid sparing agent and it maintains remission in both ulcerative colitis and chronic disease. Now azathioprine as a prodrug rapidly cleaved to 6-mercaptopurine in the liver, and now 6-mercaptopurine via enzymatic pathway, they will produce 6-methyl-mercaptopurine and one active metabolite known as 6-thioguanine nucleotides or 6-TGN. This 6-TGN can be measured. So there is a significant correlation that if the 6-TGN level between 235 to 450 picomole 8 into 10 to the power 8 RBC, then that is highly correlated with good clinical response. And when we are talking about thiopurine non-adherence, that means if it is less than 100. So therapeutic drug monitoring of this type of metabolites can increase the efficacy, patient safety, and cost effectiveness of different other biological agents also like infliximabs. But there are some drawbacks associated with therapeutic drug monitoring. What is, we all know about white coat hypertension. Here we are talking about white coat adherence. What is that? It is improved patient adherence to treatment around clinical visits. So I am taking 6-mercaptopurine or ASA drugs while I am going to visit my doctor and while giving blood, so that will not reflect that I am not taking drugs for last maybe 1 month. I am taking drugs for last 15 days. So this is very important area and a drawback for TDM. This is a direct method, obviously. So it has some cost and labor intensive methods. Other drugs like methotrexate metabolites in treating IBD patients, the usefulness has some question marks. While using mesalazine, we need to measure 5-ASA and N-acetyl 5-ASA by GCMS or LCMS. So they are little bit costly affair, but we can measure that also. There are easier things or indirect methods of measuring adherence like pill count. What is pill count adherence rate? That is equal to number of pills dispensed minus number of pill returned divided by number of pills prescribed multiplied by 100. So that gives the pill count adherence rate. So this is a simple, objective and inexpensive method to see the adherence. But sometimes it overestimate or underestimate the adherence. If I am not taking the drug, just taking the drugs and that the drug not enter into my system, that cause some overestimation, and sometimes it may cause underestimation also, that how much number of pills I am returning to patients. And it is sometimes difficult in our settings also. The patients who are coming from a poor socioeconomic background, from villages, it is little bit difficult and it also takes some time. Now pharmacy refill data, so they used medication possession ratio and proportion of days covered method. So this is a popular methods in US, but we know that in our pharmacy we don't have any data. So what is medication possession ratio? It is defined as the proportion of days supply obtained over refill interval or fixed interval. And what is proportion of days covered methods? That defined as the number of days covered over a time interval. So it generally assume that patients with an MedpeR or PDC more than 80% are classified as adherent to their treatment. There are some electronic monitoring devices also, like medication event monitoring system. Medication bottles contain some microelectronic chip, so registers the date and time of every bottle opening. So I am opening the bottle, it is registered. So provided that each bottle opening represent medication intake. So otherwise, again, this will not serve the purpose. It is expensive and no guarantee that the medicine which is removed is actually consumed or administered correctly. There are some self-reporting things like patient kept diaries, patient interviews, and some standardized validated questionnaires. So this is one very popular scale, 4-item Morisky medication adherence scale we will find in the net. So we can understand the score and we can judge about the adherence. Apart from that, there is a IBD specific validated 8-item Morisky adherence scale. So while treating our inflammatory bowel disease patient, we can have this scale and we can score them and we can understand the adherence level in those patients. So these are the very simple question we can ask the patient, and as per that we can calculate their adherence. So how to improve adherence? So number one is education. So education has very importance here. And as we are starting with some talking about some pathophysiology, so pathophysiology is also very important. While talking with our patient, if we can make them understand about little bit of disease pathology in their term, in layman's term, so that can improve adherence. So etiology, pathology, anatomy, investigation, medical surgical treatment, mechanism of action of the medication regimen, dosing schedule, potential side effects of the treatment, and we should also ensure them not to be worried about that, and when they need to be worried. So everything we need to talk. And we also give focus on consequences of non-adherence, disease course, the risk benefit of using drug and not using drug. So risk of using therapy and risk of not using therapy, importance of nutrition and other complications of IBD. We need to educate our patients. When patient require surgery, so that also need to be focused while giving some therapy to the IBD patients, because that fear of colectomy that may increase the adherence. So behavioral intervention is very important. Shaping, reminding, or rewarding desired behavior. So that also known as reinforcement. So cognitive behavioral therapy that use the principles that negative thoughts can block the abilities to act and learn new behaviors. So consume medications at the prescribed time or refill medicines. So we need to talk about these not believing medications could alleviate symptoms. Also, we need to talk about that we need some medicine to continue. Otherwise, your autoimmunity again will trigger, and that will produce different symptoms, which sometimes you may require surgery also. We need motivational interviewing, telemedicine with subtypes including telemonitoring, tele-education, teleconsultation, and telecare. That also improve adherence. And some pharmaceutical modifications is also important. So just like an example, that if we all know that when we have polypharmacy has a more chance of being non-adherent. So if we can address that issue, polypharmacy, that can help us. So once day formulation of mesalapine by using some technology like multimatrix system that release mesalamine in the colon, incorporates mesalamine into a lipophilic matrix within a hydrophilic matrix encapsulated in polymer resistant and to degrade at a low pH less than 7, and that causes delay release throughout the colon. So this type of modifications will be helpful. So coming to my epilogue, that we should be very simple while prescribing any drugs to increase adherence. So number one, we should simplify the regimen. S for simplifying the regimen. Number two, impart knowledge or informed prescribing. M for modifying the patient's belief and behavior. P for provide communication and trust. L for leaving the bias, and E for evaluate the adherence. So it is not only, we should also give emphasis in revisit when patient will come for revisit regarding what happens to the adherence after our intervention. So evaluating adherence is very important, and here we need to give on another importance on another E. That E is empathy. So we should not blame, we should not shame our patient if we found our patient to be non-adherent. So we have to address this issue little bit in a empathic attitude. So with that, I thank you once again for giving me this opportunity. Now I can, if we have some discussion up now, I am open to it. Over to you, Chairperson, sirs.
Hey, thank you, Dr. Sambo. This is a didactic lecture with accomplishment, like a teacher. You have made it, and we have knocked the different doors, different areas, including the basic areas also there. I acknowledge you. It is very good. I was listening to your lecture. So
thank you.
Definitely it is a good teaching for even for the gastroenterology students also. Yeah, exactly. So you have covered all these things, and you have said about the what is that efficacy of the drug with this is the 6 TGN levels. Okay, whether efficacy is there or not. There is another thing is that the safety of the drug, that is TMPT, that thiopurine methyl transferase. You have to mention whether he and she can tolerate that, or there will be side effect or not. Okay, so you have covered everything. The pro-inflammatory interleukins and anti-inflammatory interleukins, including form. This is the anti-autoimmune phenomena. So this is good, and mostly it is very informative. So if there is any question, anyone, you can ask Prateik. You can ask also if you think you can interact.
No, sir. Actually, I just wanted to make a few points. I think mainly with Shambho's excellent presentation. So I think it covered everything, like you mentioned. It's covered everything. Only a few points from a gastroenterologist perspective regarding adherence in patients of IBD. Now, we get a lot of patients of Crohn's disease. I mean, personally, I get a lot of patients of Crohn's disease in my practice, especially in Medica. I mean, at least 7, 8 odd patients every week we are getting of Crohn's. I think it's maybe East India we're getting, because in Western India I used to get a lot of ulcerative colitis. Here we're getting a lot of Crohn's. Now, the problem with this is, again, therapy needs to be lifelong in most cases. And there is the problem of, like you mentioned, the side effects of the drug. So even if you start with the drug, and even if you do, now one thing about TPMT mutation, there is a big controversy regarding TPMT mutation analysis now, because TPMT is not the only mutation which can cause these patients to have severe side effects to azathioprine. There is another mutation called NUDT, and the work has been going on with that mutation as well. So in Bombay, Dr. Desai is working on that, and NUDT mutations have been found to be more common in our country now compared to TPMT, and work is going on that. And both actually will cause problems in patients who have this, who are using azathioprine. Now the problem is this compliance of azathioprine, and in Crohn's disease, long-term therapy remains a challenge because the patient has to be on steroids for long. Then the patient is tapered off onto some immunomodulator like azathioprine or MMF or any other drug. And if not so, even if the patient is on adalimumab or infliximab for that matter, the side effects can be very extreme in a few patients. And not all the time it is predictable. Sometimes it can be idiosyncratic as well. And so this is something which is a problem in most patients, and with compliance and adherence. I have a few patients who came to me with chronic anemia, found ultimately to be Crohn's disease. We are treating them. Now, asking them to be on therapy is difficult because sometimes they've got some side effects to azathioprine. Now, you stop it and you change over to another drug. They keep stopping the drug because the anemia is very gradual. So they don't realize the importance of taking the drug compared to stopping the drug because they want to stop the drug. I think that is a very important problem with IBD, because unless you come with a flare and the patient has had a life-threatening episode, those ones which come with a gradual worsening, they don't realize the importance of drug therapy. And I think in all the summarization of all what we are speaking about now, if the patient knows what the issue is, if the patient realizes the problem that they're going to deal with at the end, that is a time when adherence improves. I think even under adherence as well as over adherence. Like Dada's excellent topic that is about PPI, again over adherence. So the problem with over adherence, fortunately, I stop PPIs for 90% of my patients. But the point is that they come to me with PPI therapy for maybe 5 years, 10 years, 15 years. I think all gastroenterologists and even Dada must be seeing such patients. And the problem is the PPI has become now an OTC. So it has been an OTC. And once you categorize a drug as OTC, they pop it SOS. They feel that the drug is to be popped SOS. And this causes issues. This causes problems. And one more point with Rahul Das presentation about drug therapy for H pylori. Whenever we're using the clarithromycin, metronidazole based regimens, so there is almost 50 to 60% resistance to metronidazole at this point.
Yes, go on.
And this is a problem because we are using the triple drug regimen, and it's not supposed to work in most patients because they're already resistant because of over-the-counter availability of flagyl and metrogyl and so many drugs and clarithromycin and amoxicillin and overuse. So we are using more bismuth now. Of course, bismuth is now available in India, and bismuth actually works to improve the patient's clearance rates, and it has been shown. But this is a problem. So overuse is a big problem, and underuse, of course, like we all mentioned, is a problem. So with GI, the thing is, the problem with specifically GI is most diseases are chronic. You talk about chronic pancreatitis, that's another topic altogether. Chronic pancreatitis therapy, again, compliance and adherence. So Crohn's disease, IBD, like my topic, all of them are chronic drug therapy regimens. So the patient does not realize the significance unless it is life-threatening. So unless you're dealing with a patient who has cardiac disease or anything of the sort, the patient tends to stop therapy. And unfortunately, the patient comes to us in the emergency room, and then there's not much we can do. So this is the problem that I usually face in a lot of patients.
I think
No,
I think the problem is that in chronic, the inflammatory are not fit to use the biologics. If you use biologics, the time period also longer, and you can do your treatment yourself. The problem is the money. There is no insurance here, and if there is no contraindication, biologics is a very good thing, and you can also surveillance them time and they can also do. I have seen a patient, he's taking in a hostel, he's taking biologics. He's a patient of Crohn's disease. It is not
So I think there's a network problem which was
imaginable in
Yeah, I think
So there's a network issue at your end. We can't hear you, sir.
because the insurance company, they
Rahul,
will
you're
also
muted.
they will not
Rahul,
allow
you're
you to
muted.
take more drugs. They will always question you. No, but you have to pay routine cage for this patient. There may be group also there, so they can. How can you? Hey, I am disconnected.
Yes, sir. There is some network issue from your side, sir. Sometimes voice is breaking.
Okay. So I think that group insurance or insurance, something like that, maybe government insurance. Otherwise, no, there will be problem. The people will give, the doctors will give a lot of drugs, useless drug, and some people, they need drug, they cannot get drug. Okay, and the therapy should be like that. Biology is other thing. You can give it not regularly, maybe 15 days or something like that, some gap, and you can also there should be a network group also there, because they teach each other, and in that there may be a doctor also. Oh, okay. These are the things that that Sambhu can tell us about that. You know, networking and group therapy and group thing and group formation for a chronic disease. Insurance very important. Then doctors will be also stopped or overprescribed. They'll ask question, why are you giving this thing? They will not allow the money. You know that? Santanu, just take it.
Yeah, taking
Sorry.
cue from what Dr. Pravid Banerjee was mentioning about networking, etc. I would like to raise an issue for patients visiting the specialists and super specialists for chronic diseases which require long-term therapy. How and to what extent it is important for continued follow-up visits and patients failing to comply with such requirement. And in such a situation, whether there is a need to also have a primary care physician at a remote location to be in the loop, so that primarily whatever is diagnosed and the primary prescription given by the specialist or super specialist, the patient can constantly be in under closer monitoring by the primary physician, who will be responsible for ensuring better adherence. I think we need to have this kind of a solution which really might help patients in our country. In my understanding, many patients, they will first make a visit to a specialist or a super specialist and will have a few visits only and then stop it, because many of them are distantly, remotely located and might not be, for different reasons, maybe financial and otherwise logistic reasons, would not be complying with the requirement of continuous monitoring by the specialist or super specialist, and there is a premature
Sir, I think your network is something which is disturbing. I don't know, but what sir is want to mention that we need some our primary care physicians also need to be, we can say, there should be empowerment to the primary care physicians also regarding this issue, and I think that can help the adherence in a holistic manner. So there is some disconnection in sir's line. I think there is network issue. So sir, can you hear us?
Yeah, I can hear you now. There were some issues probably. I don't know whether I was audible when I was raising the question.
You are audible.
Yes.
But everything we have heard from you. That's a good suggestion. But the GP, GP orientation, it is lost in India. In every country, maybe UK, USA, there is a file for a patient, lifetime file, and you can, yes, now it is electronic file also, but there is nothing here. Anybody is giving any drug, anybody is doing anything, and there is no check and balance like other spheres of our life. That's the problem. That's why so much of the over medication, antibiotics, then there will be antibiotic resistance, plasmid, everything will be there. And then there is, it's a PPI. PPI, that they're using PPI like anything. PPI misuse, use and misuse, use also. This is this is a very important instrument or important thing in alma mater, PPI, and they are using like this, and it should be short,
Sir,
brief. Yeah.
Sir, regarding this, sir, one thing I just want to mention: adherence is such a thing which we can address to at a time. We can address this issue to maybe 50 or 60 patients together. Just giving a scenario, if I am sitting in one hall and addressing 50 or 60 patients of IBD or maybe Crohn's disease or maybe hepatitis B, and in their language, if we can make them understand what about this disease pathology and importance of drugs, and talking about the adverse effects with those medicines, and what are the consequences if they are not continuing this type of medicine, I think that can improve adherence little bit. And also, if we have some pre-filled questionnaires, like very simple questionnaires like Morisky's medication adherence system score, while entering into the chamber of gastroenterologist, if they are, while they are waiting in the outside, they will just make the circle on their choices, and ultimately the score will be calculated, and the gastroenterologists have a look on that score, and that they have a idea that this patient is well adherent or non-adherent or needs some improvement.
Yes, Dr. Shambho, yes, all these are otherwise very good. The general, you can say the general advices or the general strategies for improving adherence, but then most of the time this may not be enough, and the adherence issue needs to be also addressed individually, because each individual patient is a different patient, and he has all the more reasons for non-adherence at his individual level. Somebody might be having a financial issue, somebody might be having a lack of understanding issue, etc. There are many issues. Patient's perception is something in itself is a matter of research. Okay, patient's perception, patient's treatment seeking behavior, patient psyche. So I think yes, you are, whatever you are mentioning, it's extremely important. There could be also group counseling at the clinic, but then end of the day, each individual patient is to be understood, and his problems of adherence is to be properly appreciated, and the treatment needs to be individualized, succeed. Okay, Dr. Rahul, what is your opinion on this?
Rahul, you have to unmute yourself.
Yes, sir, I completely agree. Individualization is very important, especially in terms of adherence. One-to-one dialogue between the treating physician and the patient is of utmost importance. And at the end of the day, a few minutes of time spent counseling a patient, whether it is adherence to medication or adherence to foot care protocols. I've seen a very simple 2-minute tacit message that please look after your feet this way, or you take insulin this particular way, or you take store insulin in this particular way, or you check your blood pressure so many times a week. A direct message works better. I've seen this is a very strange phenomenon I have people, for example, my chamber assistants, when they tell the patient you eat this, you eat that, you take medicine this way, that way, they are not willing to listen. But if they hear it from the horse's mouth, they hear their doctor who has prescribed that on the prescription. He or she speaks to them for 2 minutes. I've seen that the patients are much more compliant. Just a 2 minute conversation, one to one, is something which I agree with the respected Shantanu sir, that patients like to listen from the doctors.
That's great. So I think with the permission of all of you, it's already more than a couple of hours. So we have to call it a day. But before that, I have a very humble submission. You all are very busy people, but then I am really overwhelmed and really like the quality of the presentation today. And I'll just ask you to consider whether we can really compile, okay, whatever we have discussed today. And we have seen two extremes in Dr. Rahul's presentation and Dr. Prateik's presentation. We have also seen Dr. Shambho dwelling in another area, Crohn's disease and the overall the inflammatory bowel disease. And I was just wondering whether we can make a string, okay, integrate all this on the overarching theme of the adherence issue, adherence in treatment of gastrointestinal disorder, to make a write-up, okay. And I would request Dr. Shambho to coordinate with the all other experts, and I'll request Professor Banerjee also to be present in this as a mentor. I'm looking
Please,
for it. We can have a timeline
your
and make it.
Because there is a connection. There is a connection. There is no connection.
I'm just proposing to consider writing a article, okay, integrating all the issues that we have deliberated today, okay, on the theme of today's session, today's program. Dr. Shambho, if you can take up this
Yes,
challenge. And
yes, sir. So we will definitely look forward this, because this will be a great project for all of us. I think Dr. Rahul Jain and Dr. Prateik Poddar, they also will agree with me, and they will help us, help me to write up that. And under the guidance of Prabir sir and you, we'll definitely can have one review article like this, review article like things on this matter.
And the general principles that you have covered also in the later part of your presentation, Dr. Shambho, that can also be very well incorporated. Yeah.
Yes, sir.
And it can be also mentioned a couple of case studies in under each disease area that you have also mentioned. All of you have mentioned case studies also. So it will be otherwise a good write-up or good review article, I suppose.
Yes, sir.
So definitely. I think Dr. Banerjee, you can have the concluding remarks, and then if Rohan has to say something, and then we can call it a day. Thank you very much.
Yeah, today's exposure, this exposure of gastroenterology, it is very unique. That what I've seen here, and everybody tried to do his job nicely, and particularly they educated us. And ultimately that's why the level of discussion was up in a height, and I think we should continue this thing in our discipline, and definitely you are doing this thing with the other discipline too, but this group is very good. And I thank Dr. Rahul, Dr. Some painful. Everybody has given a deep knowledge about their topics. They have given time and also sweat. Their sweat. So I thank you all of them. I thank Dr. Professor Tripathi for arranging this nice feast, and also thank Dr. Your son also, because he's the prime mover of this thing. Yeah, I also thank him. I can see him because he's working in the back possibly. Thank you.
So now
Thank
it
you.
is over to Rohan.
Yeah.
Thank you so much. Thank you so much, sirs, for all your wonderful deliberations. It was just incredible to hear various sides of the non-adherence coin, going from the under-adherence to the overdoing the medicine part. And another thing that was encompassing in the entire evening, that was the need for the human approach when we are dealing with adherence and compliance and general patient treatment. So I especially thank Dr. Banerjee and Dr. Tripathi for chairing over this evening and chipping in with their very worthy comments after every session. Thank you so much. Thank you so much, all the speakers, for your excellent presentations and time. And it would be really an honor if we can actually take forward this evening in the matter of a write-up or an article or a paper that can be carried forward to give even more meaning to this evening. With all your permissions, I would also like to say that since this was being broadcasted on Facebook, this evening has been recorded. So, if we have your permission, we would like to release this on YouTube so that we can reach even more people with this. So, with all your blessings. Also, I would like to take a selfish moment to let everyone know that Inovocare, we are trying to develop a device of medicinal adherence, and where we are trying to bridge this gap of infrastructural and economic requirement, which typically stops the usually available devices for adherence being used by the general public. So we are trying to develop it. We are on the verge of getting the field test ready. So with all your blessings, very soon we will be able to, introduce the device to all of you. With that, seeking all your blessings once again, and thanking everyone for this great evening of such awesome deliberations. I would like to end this evening. Thank you all for coming, and thank you so much our audience. Thank you.
Thank you.